Here is thanks. Sir, thank you very much for inviting me. I also see radiologists have taken care of it, like Dr. Sandru. And before we start, I want to thank, and Raj and me and all of us actually, want to thank all my colleagues in Bakersfield who have helped our careers by sending us very complex patients, some of which we could help and some of which we couldn't. Thank you very much. So this topic is actually very, very dear to me, and I'll tell you why it's very dear to me. Prevention of stroke with new devices instead of drugs. And most people think that MitraClip is something very interesting to me, but actually this is a topic which is dear to me because my father. So these are my disclosures. As you can see, I get grants and research support and consultants from every single company, so I'm so conflicted that I'm actually very neutral. I take money from everybody. When you talk about cardiovascular stroke, there are many sources. Cardiovascular stroke means that the heart is the cause of the stroke. That means the clot went through it or originated from the heart. And there are many causes, and atrial fibrillation, valvular heart disease are the commonest, and then of course you have paradoxical involvement of PFO. Because of time constraints, I'm only going to speak about atrial fibrillation and PFO. For those who have not seen strokes, or those who have family members who haven't seen strokes, stroke is perhaps the worst thing that can happen to you by family member. It is much more devastating than actually a heart attack. My father was a very famous cardiologist. His life ended in a very horrible way when he had an ischemic stroke from AFib. His first manifestation of AFib was a stroke. He never recovered for it. For 3.5 years, he tortured himself and he tortured my mother. And we finally succumbed to it. This is therefore a very sensitive topic to me. So anything that can reduce the incidence of stroke is meaningful. So I'm going to start first with a less mundane topic like PFO and strokes. And we all know that PFOs are a normal variant. 25% of us have PFO. If Bridge Bambi was allowed to do it, he'd probably disclose everybody's PFO. But we actually don't need to. On the other hand, if you want to find out if you do have a PFO, is it a problem? I get all these consults of patients with PFOs. These young patients come in, actors and actresses say, I have a PFO. It's like a fashionable thing, I have a PFO. And it's nothing, it's a very Beverly Hills thing. So you say, no, it's okay, you don't have to do anything. And there's actually one study to show you that if you follow patients and you actually classify them in patients like, I'm a PFO and I'm not a PFO, then you can actually go and find out if you follow them for 5 years, there's actually no difference in stroke rates. So in a given patient, if you do have a PFO and you don't have any other events, you probably shouldn't do anything to that patient. But what if you have a PFO and you had a stroke? Let's say you have a patient who's 59 years old, there's no other cause of stroke, and you find that he has a PFO. And you follow these patients, and you give them all aspirin, and you take 500 patients, and then you follow them, you see what happens. And if you follow these patients, you can see if you have a PFO with atrial septal aneurysm, which means a large PFO, your recurrence rate of stroke is almost 4% per year. So 35% will have another event in 5 years. On the other hand, if you have only an atrial septal aneurysm, or you have no PFO, the recurrence rate of another stroke is very small. This is the retrospective data which supports that PFO might be a cause in some young patients. What about older people, above 70? Well, we always say, well, if you're 70 years old, you're going to have a stroke and a vascular disease. But that's not true. You can have people who are very clean vascular stroke. And if you see, even this group of patients, if you do have a PFO, and you had an event, there is a higher chance that you will have a recurrence. So there is therefore an association between cryptogenic stroke and a PFO. So the summary is, this is what you should know. In a general population, the presence of a PFO is not an independent risk factor for stroke. However, in patients who've had a history of a stroke and do have a PFO and atrial septal aneurysm, the risk of recurrent events are high even on aspirin. The question is what you do with these people. So the options are you can treat them with Coumadin or antiplatelet therapies, or you can consider closure surgically or percutaneously. So if you look at this, the PFOs are, the basis of closure of PFOs came from closing of atrial septal defects in children. So the methodology is very simple. You can do it, and I think you do it in Bakersfield, right? You do PFO closures. So what you do is that you can do it with intracardiac echo, local anesthesia, venous puncture. You go up the IVC, you find the PFO, usually it's quite easy to find it. You cross the defect with a catheter, and then you take a double umbrella device, a suitable size, you deploy the left disc, and then you pull the whole system against septum, and then you deploy the right disc. This procedure takes 35 minutes. The patients go home the next morning. You give them aspirin for 6 months. You give them Plavix for a few months maybe. And you do a repeat echo and it shows it's completely closed, it's fine. How do you diagnose these patients? You do a simple thing like a bubble study. And you can see this is a strongly positive bubble study showing the right to left shunt of PFO. The septum is intact. And this is a patient who actually had closure. You can see that's a helix device. That's the right atrium on the top, that's intracardiac echo, and there's no defect, no blood bubbles crossing from the right side to the left side. So it's actually quite a reasonably simple procedure. But the question is, does it really work? Does it make a difference? Most of us would like to believe it does. Because cardiologists, as you know, are like, natural predators. We like to go into everybody else's business. So we take the coronaries, then we went to the valves, now we want to go after stroke too. So let's look at the data. So there are 3 trials that you can see there, RESPECT, Closure 1, and the REDUCE trial. And if you go and understand these trials, 2 of these trials have completed, 1 is still enrolling. So what are the challenges of enrolling these patient studies? It's very difficult studies because you have biases. If you go to a cardiologist, like Rich Bambi, he'll say close the hole. If you go to a patient, he'll say, I don't know. If you go to a neurologist, the neurologist say it doesn't make a difference, take medical treatment. And then you have patients. Now the patient's the biggest problem. So we are living in Beverly Hills. So you have these young patients who come around. 50% of them are actresses. And the other 50% are waitresses trying to become actresses. And so you go to them and say that, you know what, you've had a small stroke and you have a PFO, and she says, close it. I said, no, wait a second. It's like we're not sure about the data because it's sticking a medication like aspirin for life versus actually putting an implant in your chest. He said, Dr. Carr already had 2 implants, another one won't make a difference. So you can't do that. So it's very difficult to enroll these patients into any of these studies. But anyway, we did finally manage to enroll some of these studies. This was the first trial, called the Closure 1 trial, where we randomized people reluctantly to medical therapy versus closure alone. 500 patients, a superiority design. I'll just show you the end result. The end result that you see, numerically, there was a reduction of neurological events in the device arm compared to the medical arm, but the numbers were small and it didn't get the statistical value. For a patient who looks at the numbers and says, hey, that's less, I'm going to have it closed. But for a statistician, this is not good enough. So that was the data. So we didn't meet our endpoint, even though numerically we were slightly better. The next trial is the RESPECT trial. This trial was actually slightly better conducted. This was with the Affluent device. And this is the device on the left side, purple. And this is the trial results. You had 499 patients enrolled to the device, 451 to medical therapy, and the medical therapy unfortunately varied. Some people were given aspirin, some people were given clopidogrel, some were given warfarin. So this is the problem. The procedural success is very high. If you basically divide these patients based on intention to treat, that means if you're randomized into the device arm, whether you got device versus those who got medical therapy, 16 people in the medical person had strokes. In the device arm, there were 9. For a person who's like a person like me, who doesn't understand statistics, will say, well, this is positive. But for a statistician who looks at the whole graph and said, well, it didn't reach statistical value. We then look at the data in a simple way that did all these patients actually have strokes? Now, if you actually took it as treated, many of the patients who did get randomized to the device actually didn't have the procedure done. Because they watched, they didn't want to get done, or they waited for a few months. And if you take that group of patients based on people who really got the device versus those who continued medical therapy, it's 16 versus 5. So there are basically 4 people who actually were randomized to the device arm, never got the procedure, and actually had strokes. And then you see that value becomes statistically significant. So it becomes 77 reduction. Again, for a simple person like me, this is a positive data set. So anyway, but for a pure mathematician, this is not correct. So what are the relationships with the shunt size? If you have a large shunt, there's a higher association with stroke than expected. And if you have an atrial septal aneurysm, the benefit seems to be slightly better. So the conclusions are, for the patients with cryptogenic strokes who have a TFO, based on the intention of trees analysis, it was not statistically significant. However, if you look at other analysis based on as treated, it was actually superior. And the closure of a PFO is an extremely safe procedure. This is the total meta-analysis of all the studies put together, 3.7 versus 5.2. So the actual absolute difference is 1.5%. It's small, but I think it's meaningful. It did not reach statistical value. So we're still in the FDA, so we still have another trial going on. It's trying to prove a point, and this is the reduced trial. There are only 46 patients left to be enrolled, where the same thing, they're enrolled to this new device versus just antiplatelet therapy. So this is the 2014 guidelines in ACC, and this is a very problematic guideline, and you should know this because this is what Medicare says. If a patient has a PFO and has had a stroke and comes to you, this is what the guideline says. If he's not on anticoagulation, just give him antiplatelet therapy. Antiplatelet means aspirin or Plavix. Class 1, with no evidence, level evidence B. If you have a DVT, you've had a PFO and a stroke, then in clear cut, anticoagulation is indicated with Coumadin, or PFO closure may be indicated. That's a class 2B increase. It means if you have a patient who's had a PFO and a stroke, and he obviously has a DVT, then it's okay. But the problem is, if you do come with a cryptogenic stroke for the first time, and you don't have a DVT, they've actually called it a class 3 indication, not to close it. This is a new change which has been challenged in neurology, why they made it class 3. And therefore the only option you have for patients at the present moment is very problematic, because the insurance companies are not paying for closure of PFO. And so the only way they can get it closed is to be in a trial, or they've had more than one event, and then they've had a stroke with PFOs. And that's why I'm telling you this is a problematic issue with the neurology guidelines which is being challenged. So with that, I'll close the topic of PFO, and we'll answer questions later. I'm going to talk about this topic, which is more important and large in population, the role of atrial fibrillation in stroke. Now, you've heard two speakers before me who said very nicely about the treatment, the risk, and I'm not going to go through it. They've actually already set the stage very nicely for me. We all know that ischemic stroke is the major complication with atrial fibrillation. We also do know from previous talks that warfarin works, and the newer drugs also work. However, long-term anti-thrombotic therapy has problems. The first is bleeding. And people say, Dr. Arora just mentioned very nicely, he says, you know, they bleed less in the brain. And Eugene Braunwald was asked this question. He said, listen, you can't have a free lunch. If a drug prevents a clot, it's going to bleed. And if it doesn't bleed, it can't prevent a clot. You can't have it both ways. And so we've seen that with NOACs, that they actually have a lot of non-cerebral bleeds, like GI bleeds and cardiovascular. Second is compliance, taking the medication on a routine basis. We don't know if you don't take it for 3 days what happens. The third is drug failure. There are patients, in spite of medical treatment, actually fail. So for these reasons, there's a need for something different. And finally, there are patients who can't take these drugs. And so we all know that 91% of the clots in atrial fibrillation are formed at the atrial appendage. So it makes sense that if you remove the atrial appendage or you exclude the atrial appendage, you may reduce the risk of stroke coming from the atrial appendage. You don't reduce the risk totally because you can have strokes from other causes. And so there are several such devices that have been developed. These are the LA occlusion, endocclusion devices, which I'm going to talk about, one of them. And this is the one which has the most data, called the Watchman device, now procured by Boston Scientific. And then you have the procedure. The procedure is done under catheterization there under TE guidance, and a standard transeptal puncture is performed under echo to make sure that you enter the atrium in the proper position. A suitable size guide catheter, which is 12 French, is advanced into the left atrium with a wire, and then you make sure that you cover it with the wire. You use a pigtail catheter, and then you advance the whole assembly into the left atrial appendage. The use of the pigtail prevents trauma to the atrial appendage. Once the sheath is placed inside the atrial appendage, you use a suitable size device, which is 20% larger than the maximum ostium, and then you de-sheath this device. And then what happens is the device is then just unfolds like this. It opens up, and it grabs the appendage by little anchors. You pull out the device and make sure it's anchored. You make sure it's compressed, You make sure by echo there's no flow around the device. What if there's a flow around the device? You can recapture the device and try it again. So you can reposition it, remove it, and put it for settings. Over 45 days to 6 months, it gets covered with endothelial tissue, and it becomes non-thrombogenic. So this is the other procedure. How do I go back? My slides. So the next procedure is called the Lariat Device. Now this is a device which is not approved for LA appendage occlusion, but it's been approved for soft tissue. How do we go back to my slides? Are just links. Now this problem I had with the slide presentation, it was because of Boston Scientific, because they were anti-Lariat. So it didn't actually work. So this technique, what you do is you do a blind pericardial stick, which is and then you advance a sheet in the pericardial space. You then advance another catheter into the left atrium, and you put a magnet tip wire to the tip of the apex of the appendage. You then use another wire to the pericardial space, which has got another magnet tip, and then you just advance it. And once you advance it, you can see what will happen is you're just inflating a balloon to position it. And now you know you're in the atrial appendage. So as you advance it, the magnet tips meet each other, and you now create a rail. And then once you've established a rail, you open up a lasso, and then you go over the atrial appendage. All of this is done by fluorescence, just X-rays, and echo. And then you just lasso the atrial appendage, and that completely closes it off. The beauty of this procedure is that you don't leave anything behind inside the heart. There's no device to enter, so it's completely from outside. The disadvantage of the procedure, of course, is that if you have history of pericarditis or history of bypass surgery, or your atrial appendage is too large, you can't do this procedure. So you have limitations which you can do. So basically, let's show you what's the evidence of the data. Okay? So basically, it comes from randomized studies and from registries. And really what I'm going to focus on is the randomized studies. And some of the slides that I'm going to show you are the slides that we showed at the FDA about a month ago. The total evidence of data comes from 2 randomized studies called PROTECT-AF and PREVAIL, and 2 registries called CAP1 and CAP2. And so for the total number of patients enrolled are 2,400, and the follow-up is almost 6,000 patient years. So you have 6,000 patient year follow-up. Of course, Dr. Arora is going to tell me that, well, it doesn't match the drug trials, which are tens of thousands of patients. That is true, but in device trials, it's difficult to do large numbers of that. If you look at this data, we had 2 endpoints, the safety of the procedure and the efficacy of the procedure. And the efficacy was based on a composite endpoint of all-cause stroke, systemic embolization, and cardiovascular or unexplained death. And the design was Bayesian. There was clear procedural issues in the initial part of the study. You can see there were issues in the beginning. It was 7% complication rate, primarily in form of cardiac tamponades, procedural stroke, device embolization. So in 2009, when we went to the FDA didn't like our data of safety. As you can see, over time, with experience, that complication rate has reduced dramatically to 4.2%. And the incidence of periprocedural stroke or device embolization is less than 1%. And the only complication now that's left is a small incidence of pericardial effusion. If you now look at the efficacy, I'm going to take, instead of boring with multiple slides, I'm going to show you this slide set. And let's look at the all-cause efficacy, total efficacy. If you look at the ischemic stroke rate, that's called the ratio. The total efficacy is 0.8%. That means there were less events, 80% less events in the device arm compared to the medical arm. So you will look at it, and Dr. Roy, you look at this data very carefully. So the rate ratio, p-value is 0.22. So we are by definition non-inferior. If you look at the ischemic events, there was 1.8% higher ischemic events in the device arm compared to the medical arm. And Dr. Chud is looking at me and saying, wait a second, this is not good. The event rate is 0.5. If you look at the hemorrhagic strokes, it was significantly lower. You had shown me that NOAC data, there was 40% reduction. This is 80% reduction of hemorrhagic strokes. So if you look at all-cause strokes, therefore they become equal. But what about cardiovascular unexplained death? It's 1.4% higher, but 0.07 p-value. Does this bother you? It does bother you. That is, this slight signal of mortality bothers you. If all were equal, you're concerned about this mortality. But that's actually not the data. This is the real data. I just tricked you. And what the trick is, that look at it now. This is the real data. So the real data is that all-cause efficacy is almost similar. If you look at ischemic events, it was higher in the device arm over follow-up. But I do want to tell you that the ischemic event rates in the PREVAIL trial, which is the second study, was less than 1%. There is no study that I know where the ischemic events in Coumadin is less than 1%. Everything is between 1.2. If you look at the hemorrhagic stroke rate, it's extremely low. And look at cardiovascular unexplained death. It's 0.48. So and this is a narrow confidence interval and is statistically significant. The FDA looked at this data and called this noise. And that's why I tricked you. I said if I showed it to the other side, they would be jumping over us and saying the watchman kills patients. On the other hand, when we had a mortality benefit, they actually called this noise. And this is important data because this is a data set which has occurred over 5 years. There's actually mortality. The reduction of mortality is much higher than any other drug trial. If you now look at the average stroke, so one of the questions that you can ask me, wait a second, about the ischemic events. The ischemic events are problematic. So therefore, the FDA asked us to analyze the data and said, what if they were not on medical treatment? What would the stroke rate be? If you're in PROTECT-A with a CHAD score of 3.4, your actual stroke rate should be 6.2, but the ischemic stroke rate was only 1.3. If you look at the PREVAIL trial, which was the latest trial, the ischemic rate was 3.8, 2.3%. The average CHAD score is 3.8, with a large confidence interval. It was a smaller study. If you look at the CAP registry, which is 500 patients, the actual ischemic event is only 1.2. And the expected stroke rate should have been 7.1. So if you put it to summarize all of these event rates, the actual ischemic stroke events are between 1 and 2%, which is expected for Coumadin. So what we were trying to say is that we're not trying to eliminate stroke. We cannot eliminate stroke, because any patient who's old will have a stroke. But what we want to be equivalent to Coumadin, but have less of the hazards of long-term bleeding with Coumadin. And if you look at these cardiovascular unexplained death, the deaths were explained by bleeding. Many of these patients were patients who had hemorrhagic strokes. Now the next part is even more important. What were these strokes all about? And if you look at the disabling versus non-disabling strokes, there's a higher amount of people with disabling strokes in the medical arm compared to the device arm. And why was that the case? And the case was very clear-cut. First of all, hemorrhagic stroke are much more devastating, so we know that. And the second is that the ischemic strokes that did take place were largely infarcts. So putting them together, the devastating strokes were much more in the medical arm compared to the device arm. So that's why we summarized all of this data together. And then we had another slide which they wanted to show that where does it stand? So if you look at this graph, this is the ischemic stroke rate per 100 patient years. That is your CHAD score. Okay? The top line mentions if you were not treated. If you were not treated, based on your CHAD score, that's what your rate of stroke would be. On the other hand, if you were treated with medical therapy or a device with anticoagulation, that's what your line would be, the dark line, right, to the CHAD score. If you now look at the data, the PROTECT-AF trial, The actual data set is below the line. If you look at the PREVAIL trial, it's just above the line, and the CAP registry, which I didn't show, is actually below the line. But look at the warfarin arm. The warfarin arm in the device PREVAIL study did much better than expected based on the challenge. So if you summarize this whole data, we feel that it does have an anti-ischemic effect. And this is, of course, the relative mortality reduction versus warfarin. This is not a direct study, it's just taking the other studies together. That the maximum benefit of mortality came from the Watchman device if you compare that data versus medical therapy versus warfarin. So we summarized this data together in our last slide to the FDA was, it's a safe procedure, few early but no late events. The Watchman is comparable to warfarin for the primary endpoint of stroke, embolization, and cardiovascular death put together. The ischemic stroke reduction favors warfarin. And why does it favor warfarin? Two reasons. One is that the device may be thrombogenic, there may be leaks. And third, ischemic warfarin has a pleomorphic effect. It also prevents stroke or other causes, which we don't talk about. Watchman is clearly superior for hemorrhagic stroke reduction. Watchman is superior for disabling strokes. And finally, Watchman is superior for cardiovascular unexplained death. So summarizing, we went for a panel vote. This is what the panel votes. And those who have not attended an FDA panel, at the end of the discussion, the panel is given a label, and you have to vote on this label. This was the label that they've asked us to vote on. And you can see clearly, we as a company, as investigators, went out to say that this is a second-line therapy, not a first-line therapy. Yet, the FDA put us into a position to say as a first-line therapy. And the vote was as follows. When it came to safety, it was 12-0 in favor. When it came to efficacy, 6 favor, actually it was a tie of 6 all, and the chairman voted against us. When it came to overall risk versus benefit ratio, it became 6-5, and the chairman again voted against us, against 7-5. So it actually was a close vote, but in support. So what it tells you, and then the chairman of the FDA asked questions to those who voted against. And he said, why did you vote against? And he asked 3 physicians. The first physician he asked is that, you voted against, and she said, what if I told you this was a second-line therapy? That means this is not first line for those patients who cannot take Longate. Would you have changed your vote? And she said, of course I vote. I changed my vote. He asked the second person, she voted yes for safety, yes for efficacy, and she voted against no for risk benefit. So Dr. Zuckman said that this doesn't make sense. How could you have voted yes for the third one? And then she answered, she just said, I don't know, I wasn't sure about which patients to be treated, so I voted against risk benefit ratio. So then Dr. Zuckerman said, what if I tell you it's second-line therapy for people who cannot take the medications? He said, then I would have voted against that. Then they asked the cardiac surgeon, and the cardiac surgeon answered the best, I think. And the cardiac surgeon said, this is exactly what we face every day. It's a metallic valve with Coumadin for long-term therapy versus a bioprosthetic valve, which is a shorter duration and you don't take Coumadin. You have to have both therapies available for patients. There are some patients who cannot take long-term anticoagulation. You have to give them, and that's an important valve. So that was his point, so he voted yes for all 3. So we summarize in saying that based on all these findings, LA closure is a reasonable alternative to long-term anticoagulation in patients. Not for all patients, not as what Pete said, patients who are stable, but those who are having problems. Those who cannot take medications, for example, they've bled. Those who should not be taking, for example, patients who've had aspirin and Plavix for drug-eluting stent. Now you have aspirin, Plavix, another NOAC or a anticoagulation. And those who do not want to take medication because they're lifestyle actors who box around, they don't want to take it. For all these people, this should be provided at least as an option. With that, I'd like to end and say that the status of LA closure in the United States is awful. There are no endovascular devices available at the present moment in the United States. LA ligation to the Lariat procedure is available and surgery is available, and we are therefore eagerly waiting for the FDA's decision. In the panel, there were 11 patients that spoke, 6 who had the device and 5 who were waiting, and 3 of those patients actually are going to Canada to get the device approved. So it's actually a very bad situation. So the reason why you realize the implications are very serious, because this is a very large population to be treated. And we know that once it gets approved, there might be a major off-label usage, and that's why the FDA is being very careful and analyzing this data before it actually approves this procedure. So we finally say that this is the end of my slides. And my last story is, do we need more studies? Or is this enough? And I think the quotation is by Albert Einstein that insanity is doing the same thing over and over again and expecting different results. Thank you very much.